Well, hip is diseased if there is pain, swelling, deformity, and loss of function around hip. The loss of function is climbing up and down stairs, walking, standing on each of the limbs separately and on both limbs together, sitting on a chair, squatting, sitting cross-legged. Now, here the pain in the knee can cause hip disease, and pain in the hip may be indicative of knee disease. But hip problem is also detected when you do a neonatal examination. And in a neonate, if there is a widening of the pelvis, the trochanter is prominent, or you can feel the bony head in the gluteal region, then you suspect congenital dislocation of the hip. So after identification and demographic data is recorded to describe the time, place, and person distribution of the event of interest. Symptoms are charted chronologically, and about each symptom, the onset, course, duration, treatment taken, response, aggravating factors, relieving factors, and associated factors are recorded and put up in English and presented and communicated accordingly. So this forms a well-stated history of the case, history of present illness. Next, you have to think about the site, nature, cause, effect, and association of the pathology. So, what is the diagnosis? Diagnosis is site, nature, cause, effect, and association of the pathology. So, you may have to ask some leading questions to either rule in a probable diagnosis or rule out a differential diagnosis. Thirdly, ask the effect of disease on the patient and the relatives. Every disease has a widespread effect on the patient and the relatives, sociologically and psychologically. So, a good history always takes care of this component. Then you must ask the patient the ability to bear the social and economic effects of the disease itself and the treatment of the disease. So, you have to look into the pocket of the patient, not to pickpocket, but to prescribe the treatment according to the pocket of the patient. After this, you do a thorough clinical examination, and all this converts into a data, and that data is used to make a clinical diagnosis. So this algorithm will help you make a clinical diagnosis. You basically classify the case into flexion, adduction, external rotation, flexion, adduction, external rotation, flexion, adduction, internal rotation, flexion, abduction, external rotation, and none of the above. So, if there is a flexion, adduction, external rotation deformity, and there is history of injury or trauma, then if the trochanter is thickened, tender, and the external rotation is complete because the fracture is extracapsular, then the diagnosis is trochanteric fracture. In a fractured neck of femur, you have tenderness in the Scarpa's triangle and external rotation is not complete because the fracture is intracapsular and the capsule is attached to the distal fragment. So flexion, adduction, external rotation, no history of injury, trochanteric fracture, fracture neck of femur. If there is no history of injury, it's a child, diagnosis is Perthes disease. If it is adolescent, then the diagnosis is slipped capital femoral epiphysis. And this is the fat, hypogonadic child, male, in which this diagnosis is usually present. Now we come to the flexion, adduction, internal rotation problem. If shortening is present, then the diagnosis is straight away posterior dislocation of hip, which can be congenital, traumatic, pathological, or paralytic. Now, this pathological dislocation of the hip can be because of a septic arthritis, because you have put in a needle in the femoral vein, which has destroyed the epiphysis, and therefore there is a post-septic arthritis, posterior dislocation of hip. Secondly, TB stage 3 can also cause a pathological posterior dislocation. Posterior dislocation, congenital, traumatic, pathological, paralytic. You must look for telescopy. You must look for vascular sign of Narath to complete your clinical examination. In congenital dislocation of hip, there are two tests. One is when you are able to dislocate Bahar-Low. So that's the Barlow test. And the second is Ortolani test, which is Under-Low. You are able to reduce the dislocation. So Barlow and Ortolani test specific to congenital dislocation of hip. Now, if true shortening is absent, there is a flexion, adduction, internal rotation deformity, and true shortening is absent, then you see whether the rotational is painful. If the rotation is painful, it is an intra-articular pathology. TB stage 2 is the common diagnosis. If rotation is free, it's an extra-articular pathology, and you have to look for ileospasm, like in appendicitis, amoebic tephlitis, filarial lymphadenitis, and all those conditions. So this finishes flexion, adduction, internal rotation deformity. Now we go on to flexion, abduction, external rotation deformity. Adduction is finished. Abduction, external rotation deformity. If there is history of injury and there is lengthening, it is anterior dislocation of hip. If the length is normal, then if the range of movement is good, it is synovial effusion. And usually the synovial effusion is because of TB stage 1. If the child is toxic and painful, then again it is synovial effusion, but this time pus is filled in this. So it is septic arthritis of hip. The second picture is there is a flexion, abduction, external rotation deformity, no movement, no pain. Diagnosis is bony ankylosis. If it is monoarticular, it is septic arthritis. If it is polyarticular, it is ankylosing spondylitis. Then if there is none of the above, trauma present, central dislocation of hip, confirmed by Morris's bitrochanteric test and a perrectal positive examination. If trauma is absent, the jokers of the hip, two jokers of the hip are avascular necrosis and osteoarthritis. After this, let us have a viva on congenital dislocation of hip. The first question is your diagnosis. You say congenital dislocation of hip. Then I ask you, why do you say so? So you say there is a neonatal examination reveals a prominent high trochanter, a short limb, vascular sign of Narath is positive, telescopy is positive, and I can feel the head in the gluteal region, which is a bony, hard, smooth, painless swelling, which rotates on rotating the hip. That means transmitted movements are positive. In an adult with this, you will have a Trendelenburg gait. If it is bilateral, what is Trendelenburg gait? It is lateral bending of trunk on the same side while the limb is weight bearing in walking. So if it is a bilateral CDH, he will bend his trunk on both sides, and that is called as waddling gait. How would you investigate? I will take an X-ray of the pelvis with both hips in identical position. What do you expect? I expect that if I draw the Perkins line from the edge of the acetabulum, this line, Perkins line, and a line joining the two triradiate cartilages, which is the Hilgener's line, then the ossific nucleus will be in the outer and upper quadrant, not in the lower and medial quadrant. So this is when I do not see the ossific nucleus. Otherwise, the ossific nucleus will be small. The acetabular angle between the horizontal and the acetabular edge would be increased, and these are the radiological signs which may indicate a congenital dislocation of hip. What should I do? I should close reduce by the Ortolani maneuver or the Bigelow maneuver. If the child is an adult, you will have to do a Bigelow maneuver to be able to close reduce the hip. Supposing you can't close reduce, then you have to open reduce. You have to understand what prevents closed reduction. From outside in, the first thing is shortened pelvifemoral muscles. The second is an hourglass contracture of the capsule, because the ileosos has made an hourglass contracture between those components of the capsule that are attached to the acetabulum, and that enclose the head. So unless and until you are able to negotiate the hourglass, you will not be able to reduce. The third thing is an inverted labrum, and the fourth thing is a filled acetabulum. So these are the four reasons. So shortened muscles are treated by releasing the abductors and releasing the iliopsoas, or you shorten the femur in the subtrochanteric region so that the contracture no longer remains apparent. The third thing is, if you want to deal with the hourglass contracture of the capsule, then you have to release the iliopsoas. Inverted labrum and filled acetabulum have to be dealt with. Then you retain the reduction. Operative reduction is retained by a K-wire across the hip, from the head into the acetabulum. And if you are not operating, then you retain the reduction by a POP hip spica, or what is called as a Von-Rosen split. And this simply maintains the hip in abduction, external rotation, and flexion till maturity, so that the head is well contained, acetabulum is well developed, and the dislocation does not occur. If the acetabulum remains shallow, you have to increase the acetabular angle by a pelvic osteotomy, which is on the upper edge of the acetabulum. And there are 4 types of pelvic osteotomy described: Pemberton, Chiari, Dial, or Salters. You can remember this name, but you will never be asked about them. As far as torticollis in the neck, torticollis is there. So there may be injury, or there is a contracture of the sternocleidomastoid, which flexes and extends the neck, which laterally flexes it and rotates it towards the opposite side. So if there is a contracture, you have to release the sternocleidomastoid, and you have to retain the reduction by the halopelvic device, which actually makes the opposite sternocleidomastoid contract, so that the length of the affected sternomastoid is gained. So this was about the today's lecture.